invasive surgery, just about as maximally invasive as we can get. But we did a randomized controlled trial of liposomal bupivacaine wound infusion for post-operative analgesic management of limb amputations in dogs. All right, so appendicular neoplasia is seen not uncommonly in our canine companion animals, with the most common being osteosarcoma. Typical for this disease management includes surgical amputation paired with chemotherapy in order to get our best long-term outcomes in these patients. When we consider this treatment plan for our geriatric patients, we're often having to navigate their comorbidities, which include commonly neurologic disability, orthopedic disability, and obesity. This is Jake here. He's kind of a very typical patient. So osteosarcoma, proximal humerus, path fracture. He's an obese boy. He's got a little bit of stridor, which you can't appreciate in this video, laboring to walk on 3 legs. So pretty typical geriatric patient that we're seeing for this type of treatment. At our institution, traditional analgesia plan includes opioids. That's kind of the mainstay pain management plan for these cases. It's a great drug. It certainly attenuates pain effectively, but as we have all sort of managed, the side effect profile is pretty undesirable, especially when we're considering using this drug in geriatric patients who already have to deal with a lot of mobility issues, neurologic issues. So seeing things like sedation, ileus, regurgitation, dysphoria, things like that might limit their ability to have a good recovery in the perioperative period. Other medications we're using include NSAIDs, although again, side effect profile can limit our ability to use these in all of our patients. Gabapentin used commonly pre and post-operatively, and then certainly local anesthetics. Our institution doesn't use Soaker catheters commonly, but using things like intraoperative perineural infusions and infusing the wound post-operatively as well. And so when we're considering sort of our pain management options, certainly I think our group specifically was really interested in sort of changing our pain management plan to sort of enable us to use opioids specifically a little bit less. And so this is what really motivated our interest in looking into liposomal bupivacaine. This is a sodium channel blocker. It's a multivesicular liposomal chamber sort of packaged, and that allows a sustained release over up to 72 hours. In people, the product that they use is Exparel. It's their liposomal bupivacaine. There's a pretty reasonable body of literature looking at its safety and efficacy sort of in various surgical scenarios. Probably most commonly would be total joint arthroplasty, so we're talking total knee, total hip arthroplasty, and generally the consensus in the literature is pretty mixed, but overall I would say sort of limited in terms of a robust clinical benefit being demonstrated. And then we have plastic surgery, so major surgical reconstructions. Again, safe drug, maybe a little bit more in terms of proof of efficacy and clinical benefit in this group. And then with nerve blocks, not really demonstrated to be superior. In dogs, it's labeled as a single-use drug, specifically for cranial cruciate ligament surgery. Our version is Nocita. In general, the body of literature that we're working with is pretty limited. Sort of shout out to Dr. Wallace, who I think is doing some stuff, Dr. Petrovsky, who's looking into this as well. So we're trying to kind of expand our understanding of how to use this drug in veterinary medicine. But in general, we've established it's reasonably safe and well tolerated in dogs. Efficacy studies have been done looking at this drug with orthopedic surgeries, so TPLO, lateral suture, and both of those studies found a clinical benefit for using liposomal bupivacaine compared to control groups. And so our group was really interested in looking at potentially expanding the use of liposomal bupivacaine to include bigger reconstructive surgeries such as thoracic limb amputations, which brings us to the objective of our study, which was to assess the effect of liposomal bupivacaine infused into thoracic limb amputation sites on postoperative pain and recovery. Our hypothesis was that surgical wound infusion with liposomal bupivacaine will improve the quality of analgesia in dogs undergoing thoracic limb amputation, resulting in lower pain scores, reduced requirement of systemic rescue analgesia, and decreased time to an improved quality of ambulation following surgery. So we designed a randomized, placebo-controlled, blinded, parallel group trial, and we included dogs who were over 6 years of age, greater than 25 kilograms of weight, who had thoracic limb neoplasia, necessitating a forelimb amputation. All dogs had to be able to receive carprofen. That was part of our postoperative analgesia plan. And so any dog that had a contraindication to receiving carprofen was excluded. We randomly assigned treatment groups and control groups. So the treatment group received liposomal bupivacaine infused into the surgical wound versus control group received an equal volume of saline infused into the surgical wound. All dogs underwent standard 4-quarter amputation, and the anesthetic protocol, including pre-medication, intraoperative care, and postoperative medications, were all standardized. So all infusions were administered by a single surgeon who was not involved in outcome assessment. The treatment group received liposomal bupivacaine at a dose of 5.3 milligrams per kilogram, which was diluted in a ratio of 1-to-1 with saline. And then our control groups received an equal volume of saline infused into their surgical wounds. And the volume was divided into tissue layers into thirds. So a third of the volume went into the muscle, a third into the subcutaneous tissues, and a third went into the cut edge of the dermis. So postoperative analgesia was provided to all dogs with an injection of carprofen at 2.2 milligrams per kilogram and continued every 12 hours, either IV or by mouth, depending on the dog's appetite. All dogs received a single dose of hydromorphone at a dose of 0.05 mg per kg IV at the time of extubation, and that was time point 0. So from then, all dogs were assessed for pain by a blinded investigator, and the pain scale that we used was the short form of the Glasgow Composite Pain Scale, and I'll show you guys the form in the next slide, but this is sort of a validated pain scoring system for dogs, and all dogs were assessed at 4, 8, 12, 18, 24, 30, 36, 42, and 48 hours postoperatively. Rescue analgesia was delivered if the Glasgow Pain Scale score was greater than or equal to 5. And if any of our patients demonstrated signs of stress, anxiety, or pain that might have been noticed by one of our nurses, for example, then our blinded investigator would apply the pain scale to them, especially if it was off of the predetermined evaluation time points. And if, again, the score was greater than or equal to 5, the dog received rescue analgesia. If less than 5, then they were able to receive acepromazine. All dogs were kept in hospital for 48 hours postoperatively in order to undergo all of the predetermined time evaluations. So this is the short form Glasgow Composite Pain Scale. Because these dogs were undergoing amputation, one of the sections we sort of was foregone. So section B we didn't apply, but section A was visual exam of the animal. Section C was a peri-incisional palpation. And then section D was sort of overall impressions, and all of those scores were tallied. And again, greater than or equal to 5 received rescue, less than did not. So we had primary and secondary outcome measures. Our primary outcome measure was the total milligrams per kilogram of rescue hydromorphone administered in the 48-hour study period. Secondary outcome measures included total acepromazine doses received, number of steps taken in a 60-second ambulation trial, and there was 3 trials per patient done at 12, 24, and 36 hours postoperatively, postoperative food intake, and adverse events. So we powered our study such that 14 dogs who were enrolled would have an 88% power to detect a 50% rescue hydromorphone dose reduction as statistically significant. And we powered our study based off of historical data from our institution regarding volume of hydromorphone given to sort of the average hydromorphone volume given to a dog undergoing forelimb amputation within a 48-hour period of time, which at our institution was 0.44 mg per kg. Data was tested for normal distribution using tests of skewness and kurtosis. 2-sided independent t-tests were used to compare means between groups, and p-value less than 0.05 was considered statistically significant. So these are the demographics between LB, which is our treatment group, and our saline group, which is the control group. Importantly, no statistically significant differences between these groups. Older dogs weighed 37, 39 kilograms, so we selected for a large breed population, and here they are. Breed, predominantly mixed breed. We had a Labrador, 2 Rottweilers, and an Australian Shepherd. BCS scores, unsurprisingly, were a little bit on the higher side. Tumor location, proximal humerus was most common, followed by distal radius or other. And then tumor diagnosis, again, unsurprisingly, was most commonly osteosarcoma. So regarding our primary results, no significant difference between the groups who received liposomal bupivacaine versus saline control. So no difference between the time to first rescue dose, number of doses received, or the total dose per dog. I think what's surprising and important to point out is that the total dose per dog with our study was 0.09 milligrams per kilogram. And if you can recall, we powered our study based off of the assumption that an average dog would receive 0.44 milligrams per kilogram of hydromorphone. So quite a substantial difference there. And the necessary postoperative dose of hydromorphone that all dogs received were not included in this value. Secondary results included total acepromazine doses, postoperative ambulation trials, which again, number of steps taken per 60-second trial. We didn't compare statistically the numbers between each trial, each ambulation trial, but you can see visually that at 12 hours, dogs are taking fewer steps than at 36 hours, which makes sense. The value listed under postoperative food intake is the number of dogs who were willing to consume over a quarter RER at the time of their first meal offered. So most dogs up for it, which is good. And then adverse events were not different between the two groups. We had an SSI in 1 dog from the treatment group, and then seromas identified in 2 dogs from the control group. So ultimately, we rejected our hypothesis that we would identify a difference in primary and secondary outcome measures between our treatment and control groups. Importantly, I think our historical data compared to our study data revealed a discrepancy in the opioid administration. So I think important to kind of acknowledge what this means for our study is that we likely underpowered our study to identify a statistically significant difference between groups. Certainly we would, with how much opioid we delivered within our study, we would just need more dogs to identify an important difference between those groups. So that's the repercussion, but why this happened I think is also important to consider. It's possible that there was, certain investigator bias here. I think probably more likely is that at our institution, we don't regularly institute a validated pain scale scoring system, or we hadn't prior to this study. And so it was, I would say, much more subjective in terms of how and when these dogs are receiving pain medications. And so having a more objective parameter to either deliver rescue analgesia or not may spare some of these dogs unnecessary opioid and potentially side effects that go along with that. I think the other thing that we kind of felt when we were doing this study was how effective we were at infiltrating the wound. Certainly the volume of solution that we had compared to the wound we were infiltrating was at times a little bit at odds. So taking an average dog of maybe 35 kilograms, that's going to be 14 mils of Nocita. You dilute that out to 28 to 30 mils of solution. That's a decently sized syringe, but if you're considering sort of the depth and length of the incisions that we're navigating in large breed thoracic limb amputations, you're sort of running out of that solution pretty quickly, it feels like. So considering methods of volume expansion, I think, would be something to consider moving forward, and potentially would that enable us to better attenuate pain in these dogs. So thinking about expanding volume with saline, reducing, kind of increasing the dilution 1 to 2, 1 to 3, something like that. Interestingly, with Exparel in humans, they actually volume expand with aqueous bupivacaine. And an important part of that, I actually had a chance to speak to a couple of Exparel reps at a conference a couple months ago, and they always recommend doing volume expansion with aqueous bupivacaine, because they notice in people there's a bit of a delayed release of the medication ablation because of the compartmentalization within the liposomal little compartments there. And so they pair it with normal bupivacaine to kind of ride out that initial several-hour period, and then they kind of count on those liposomes to start to degrade and release the compartmentalized bupivacaine. I should note that Nocita on their insert specifically cautions against doing this, and I don't think it's because there's, to my knowledge, it's strictly because they don't have safety or tolerability studies using this medication in that way. Not that we can't do it, I think we just haven't and don't know how well we can do it. Ultimately well tolerated in our study, just like in historical studies, so that was no different. And then limitations of the study, besides the limitations of every pain study, so especially in vet med, can be pretty difficult, but certainly small case numbers. Again, we talked about how we probably underpowered our study based on how much opioid we actually delivered, but certainly a bias for a type 2 error here. In conclusion, liposomal bupivacaine was well tolerated in dogs undergoing forelimb amputation, but was not associated with lower requirement for systemic analgesia during the first 48 hours postoperatively compared to dogs not receiving liposomal bupivacaine. Big thank you to Society of Veterinary Soft Tissue Surgeons, UC Davis Center for Companion Animal Health for funding our research, and my co-investigators, and then certainly all the dogs we enrolled in this study who were great to work with. Happy to take any questions.
Okay. Thank you, Dr. Gibson.
I noticed none of your infusion tissues included direct nerve blocks, which many of us do. And my anesthesiologist asked me to double inject both with aqueous bupivacaine as well as the liposome encapsulated because of the delayed effect. Have you considered doing a study that includes the actual direct nerve blocks? And my other comment you've already addressed was that your volume was rather low at a 1-to-1 dilution. So more about the direct nerve blocks.
Yeah, no, I think that's a great point. I think it feels, certainly it just feels like the volume of tissue you're trying to cover with what you actually have to work with might be more effectively done if you're targeting specific nerve bundles or field blocks. And so in human medicine, it's labeled for brachial plexus, field blocks, and wound infusions. I think it would be nice to look at doing more targeted blocking and seeing if we can be more effective that way. For sure. That's a great comment.
And these dogs did get neural injections of bupivacaine in
Yeah.
as part of our standardized analgesic plan.
Yeah. Yeah, we didn't pair it. So they did get perineural bupivacaine blocks at the time of surgery prior to nerve transection with standard lidocaine, but we didn't use the Nocita on any of the perineural injections, just on those tissue layers. Yeah.
I couldn't tell from, maybe I just missed it, how often they were getting hydromorphone post-op, these patients? Was it every 4 or?
Yeah, so we evaluated them every 4 hours for the first, I think, 16 hours, and then every 6 hours thereafter for necessity for hydro. So they got a single dose of hydro at the time of surgery, and then they got subsequent doses based on the Glasgow Composite Pain Scale.
But were they getting them, like the control group, like every 4? Like, is that what your results were?
All dogs were received scores at predetermined time points. I was the blinded investigator, so I looked at all of these dogs. We did the pain scale. We also did von Frey testing, which I didn't report here. We haven't sort of figured out how to statistically analyze that. So I haven't reported it here, but we evaluated all of those dogs. And again, they received a dose if they scored above 5.
Was that most of the dogs, like every 4 hours? I just couldn't tell, like how
Dogs
often.
on average got about 2 doses of hydromorphone for the course of the hospitalization.
So I guess my question was, do you think that your pain scoring system was good for these dogs to only get 2 doses of hydro post-op?
Yeah, that's a great question, and it's something that I was, certainly I think the worst thing would be to underappreciate pain in these dogs and undertreat them, and that was something that we were sort of like worried and navigating throughout the entire process. I think we had the assistance of our anesthesiologists who were kind of supporting. They agreed that this was the right pain scale to use. I think we freely delivered hydromorphone if they needed it. We weren't, trying to not. So I don't know how to answer that question. I guess I would say I don't feel like based on my ability to assess the animal with this pain scale, I don't feel like I was under-treating pain, but based on the numbers, it makes you wonder if we were. So I guess that's a little bit at odds, so I appreciate your question, and it's something that we thought a lot about as well.
I do have a couple questions and a little follow-up to that, because hydromorphone, theoretically will be effective as little as 2 hours, right? And so if you are, immediately post-operatively only checking every 4 hours, you might miss that window from where their post-operative hydro wears off,
Yeah.
Same with the going to every 6 hours. That's
Sure.
a very big window for hydromorphone specifically. And then who was assessing the dogs overnight?
It was, still the same blinded investigator, so I was coming in overnight to look at these.
No,
Still me.
I asked this because we do the similar pain studies, and that's one of the challenges is
Yeah.
using a Glasgow with all of the different techs that might be evaluating these
Totally.
dogs overnight.
Yeah.
And so having a dedicated person that's trained in using the Glasgow is really important.
Yeah.
From
So,
a clinical perspective, it is, even though it is validated, it is still subjective, right?
Oh, totally.
And
I mean,
so-
it's like, we don't have a good objective way of measuring pain. That's what we tried to do with Von Frey, although that's not a validated pain scale in dogs, although it's been investigated in dogs as, evaluating morphine doses in beagles, and they use the Von Frey scale, which is sort of how we modeled our study. So we decided to use Glasgow to deliver rescue hydro, but we were also using Von Frey to look at, because we wanted to know, local anesthetic-wise, how that was being effective. But certainly, regarding the subjectivity of the test, myself and another blinded investigator did the Glasgow pain scale. We did the first 5 cases together, and then, which I think was, we wanted to be able to kind of support each other's assessment, and then the two of us independently evaluated dogs thereafter. But we had the same blinded investigator doing it. The time points were predetermined, but veterinary nurses were circulating and evaluating those dogs, every hour to 2 hours. And so if they noted a concern, then they would call me and I would come in and evaluate those dogs.
And then the last couple points, you commented on using acepromazine in these dogs based on anxiety levels, and as opposed to using a true anxiolytic like trazodone or
Sure.
alprazolam or something like that.
Yeah.
And I didn't notice that you did any sedation scoring, right? Because that's
Right.
something that you should consider whenever
Yeah.
you're going to be, even if it was just for opioid administration,
Yeah.
postoperative sedation scoring is important just to consider
Totally.
for postoperative, analgesic studies.
Yeah, no, that's a great point, and certainly we know that acepromazine does confound, acepromazine can confound the Glasgow pain scale specifically. I think in terms of the other anxiolytic options, we wanted something that was injectable, and again, our anesthesiologist felt like acepromazine would be the best option that didn't have a concurrent, didn't have to be taken orally, didn't have potentially some more kind of pain management, and was typically well tolerated in the population that we were using. So it's certainly not a perfect solution, but I appreciate your comments.
All right, thank you, Dr. Gibson. Great job.